Okay, so this chapter is about guidelines, which I know you love. Okay, so I have a mea culpa, a confession to make. So when we write these chapters each year, Rick writes a lot of them, and I write a bunch, and then the rest gets spread out. And I always complain when somebody puts in a lot of abstracts for a half-hour talk. You know, like you should have 10 or 15, something like that. When you have, a zillion, it's like crazy. You can't go through them all. So I wrote this chapter, and there are 272 abstracts. No, there are 38 or something. There's a lot of them. It's way too many. But I did it for a different reason. So what I'm trying to warn you is that we're not going to go through all these abstracts. The point is not to go through every one of them. The point is to give you a sense of how large this literature is and the principles that we're going to talk about. There are many, many, many examples. So if you want to be able to cite any of them, you have plenty here. I got to tell you that we've done probably 3 times as many abstracts that I could have put in here on the tapes, and that there are plenty more that we haven't done. So this is a huge, huge area, and they're going to make the same points over and over again. But there is some value to having reproduction in different areas to make it clear that this is not just true of one thing, but it's true over and over and again, every way we look at it. So let's go with that as a start. Let's talk in general about guidelines. Why do we have guidelines? Why do we do that? You know, a lot of you remember that 30 years ago, 25 years ago, there was no such thing. And then they started writing them, and now it's like everybody has a guideline on everything, right? So where did that come from? Why do we have them? Is it any good? Is there any value to this stuff?
To set like a standard of care?
Yes, okay, so it's to sort of say, is there a better way to do it? Why would you even need to have that? What's Rick's big soapbox is variability. There's all these people doing everything on their own, and so that's sort of sometimes crazy, right? So maybe we should say that's not right. We shouldn't, there's a treasured principle in American medicine. It's between you and your doctor. Well, there is some value to that, but it's also sometimes crazy. It shouldn't just be between you and your doctor if your doctor's a moron. We should have some standards of what you should be doing. So inappropriate variability is sort of the reason that we have guidelines. Then what should you do in a guideline? What should you conceptually do? Well, you get together a bunch of people to say, do we know the answer? And if we know the answer, what is it? And here's what it is. And let's go to the literature and try to find out what it is. And if there isn't any literature, we can ask, what's your opinion? You're an expert. What do you think? Et cetera, et cetera. So that's why we should have guidelines. To some extent, I think it's rational. In Britain, they have this thing called National Institute for Clinical Excellence, which basically says, let's find out what the evidence is and try to make sure that we all sort of follow it. And they have a particular interest as well in saving money, because they pay for the national health system, and they love it and they care about it, but they don't want it to break the bank. So they don't want people to go off on their own and start doing really expensive things that don't have any value. So there's a really good place for guidelines. There could be. What's wrong with guidelines? What's the potential harm that nobody thought about? Whenever we do come up with great ideas, we never seem to think about the unintended consequences. Medical records is great. Isn't it fabulous? Electronic medical records? Except that, oh my God, we didn't think about all the ways in which it causes harm or can cause harm. So what's the problems with guidelines?
You go to court with it.
So there could be legal problems. What if you didn't follow the guideline? And okay, we'll talk about that later. But more important, way more important.
Disease-oriented approach.
What?
Disease-oriented approach.
Okay, so it might be a disease-oriented rather than a patient-oriented approach. What about this patient has something different about this patient, or this patient, their values are different, or whatever. We're always talking about the patient-oriented, and this isn't that way. What else?
They're not always clinically relevant to us.
They may not be relevant. They may be not relevant at all, or they might not be relevant to your patient population. We talked about generalizability yesterday, so maybe it has nothing to do with the patients we see in the ER. What else?
Commercial influence, conflict of interest.
Commercial influence. We're going to spend some time on that, a little bit of time on that. Yes. Who gets to write the guideline? And why do they pick that drug versus that drug? Or that drug versus no drug? What else? Sometimes variability is appropriate. Sometimes we shouldn't be doing the same thing for every patient. Patients are different. There is no one single approach that's better. What about, there is no evidence? So there are many, many possible things that could go wrong. Oh, and what about how long does it take to follow the guidelines? And how about, do people actually know them, and do they follow them? Do they actually change practice in any way? And if they do, is it in a useful way? So there are many, many, many possible, and one other thing, which is, how do they relate to each other? So if you have a guideline on hypertension and you have a guideline on diabetes, but almost everybody who has diabetes also has hypertension, do they contradict each other? Or do they recommend things that would be bad if you did both of them? And how much time would it take to follow the guidelines? When Annals of Emergency Medicine first published the first ACEP clinical guideline, which was, 21 years ago, they published a lovely editorial, which we did not abstract, so it's not in your chapter, but I reference it, I talk about it here, which talks about all these things. It says, if we're going to do this, there is a reason to do it, but we got to worry about some other things. We should be concerned about A, B, C, and D. They don't mention all of them, but they mention a bunch of them. It's a really good read if you're interested in this topic. It is cited in here. Other people have also raised some of these things, and I've cited some of them. If you're interested in a good article on this, number 2 is an excellent article on this, which talks about the pros and cons of guideline writing. Doesn't cover everything we're going to cover, but it talks about a lot of the things, how guidelines could harm the quality of care if they're not based on evidence, especially if it's done by special interests, the evidence is absent or misleading or poorly done or poorly interpreted, if it's inflexible, doesn't allow us to deal with individuals and only makes believe that everybody in the population is the same, if it doesn't change according to new evidence, how well are guidelines updated, et cetera, et cetera, et cetera. Okay, so the first series of articles is all about pluses and minuses of guidelines. And I particularly recommend, if you're interested, number 2 and the one by Schreiger et al. That I talk about in the introduction. Then let's talk about how well do they actually perform. So the next bunch of articles, starting with number 6, is about these. And I have them listed according to specialty. And I have a couple for each different specialty, and they all show the same thing. Whatever specialty you look at, they have very little effect on how people actually behave when they're measured. And why is that? Why don't doctors use guidelines? What? Too complicated. Too much time. We don't know about them. They're contradictory. When they ask, those are the reasons people always give. But in addition, how good are they? So there's a whole bunch of these. You might just know that, how about the ACLS guidelines? The biggest guideline in the world. I said we started writing guidelines in the 80s or 90s. But actually, ACLS was the first guideline, and it came out in the 70s. Huge influence on practice, right? So how good is the ACLS guidelines? So if you look, every 5 years they get updated. And every 5 years, what was right before is now wrong. But it's worse than that, because even though the guideline gets updated every 5 years, number 11 says, well, one of these says, I can't remember which one it is, says that they actually don't base it on new information. They just change things, and that almost all of it is made up, and that almost none of it is grade A evidence. My favorite thing many, many years ago was there was something which recommend, one of the ACLS recommendations, I can't remember whether it was bicarb or whether it was beryllium, or it was some bizarre thing that they eventually abandoned. But I knew that there was no information in favor of it, and I saw the new ACLS guideline, this is the mid-'80s or something, and I said, and it had a reference for why you should do this stupid thing that I knew was wrong, and I knew there was no reference. I thought, that's pretty interesting. Maybe I missed something. So I went to the reference, and I went to the library and found the reference, and the reference was a review article which referenced another reference. And I went to that reference, and I found that, and it was another review article, and there were 5 references before I got back to the original source, which was the prior ACLS guideline, unreferenced. It's a true story. Anyway, So the evidence that it's not updated, it's all out of date. They don't update it, and almost none of it is level A evidence. In fact, the large majority is what they call level C evidence, which is, I think so. Mikey likes it. How many of you remember the original Mikey Likes It commercial? Okay, all right. You know, I say that all the time when I'm talking about papers that are sort of silly. But anyway, so there's a few on that. There's one on statins, another cardiology topic. So number 14 is a paper I co-wrote with Henry Barry, which looked at the US guidelines on statins compared to the other leading Western countries, advanced economies that do guidelines. And we actually looked at what was the effect of the US guidelines in terms of dollars, number of drugs used, and benefit in life years gained. And we looked at the literature, and it turns out that the US would mean you'd spend the most, buy the most statins, get the least bang for your buck. That's good. We're the extreme, the best at doing the worst. The new guidelines are far worse. The new guidelines essentially will mean, I don't know if you're following this, but they basically came up with new guidelines which basically would say that half of adults over 60 years of age should be on statins. 1/2. And people at no risk, essentially no risk, minimal risk, should be on a statin. Personally, I would never take a statin under any circumstance for lots of reasons. That's a whole other discussion. It would take 10 minutes, but let's not do it. But one could rationally say, an informed person could say, do I want the small amount of benefit, it's a very tiny amount of benefit, at the cost that it occurs? They don't consider the cost at all. They basically lie. And I don't mean just dollar cost, which is enormous, but I mean medical cost. And when they came up with these new guidelines, immediately somebody said, your risk calculator that you base this all on is tenfold off. Tenfold. And they said, oh yeah, we knew that. But we published it anyway because it still is good. Even though they've not, anyway. Okay, so that's cardiology. Well, there's a few articles about ID guidelines. Exactly the same thing. They're not evidence-based, they're made up, they're influenced by industry. We did something a couple of years ago where we looked at pneumonia guidelines, one published by the ID Society, one by the Thoracic Society. The ID Society was sponsored by the makers of the quinolones, the Thoracic by the makers of Zithromax, or the other way around or something, and they had completely opposite recommendations. And surprisingly, they recommended the drug as the first drug was the drug of the sponsor. Amazing. I never would have predicted that. Critical care algorithm. There's just a bunch of examples. Everyone goes over. In all of these different areas, they're all tremendously flawed. But even though they're flawed, they're not humble. They all make very specific recommendations about everything. You must do this, that, and the other thing. Are guidelines following guidelines? Number 19 looks at guidelines in general. 19 and the next bunches after them. And they all say that all the guidelines that have been proposed for how you should write guidelines, nobody follows them. And what are the ways in which they don't follow them? They don't use good information, they don't use methodologic expertise, and they're all tremendously conflict of interest. So 19, 21, 22 are just some of the examples of things that give you terrible numbers about each of these things, including conflict of interest. How many people on a guideline panel acknowledge, the ones who admit to yes, no, how many of them say that they have ties to the maker of a drug that they're recommending, or a device or something like that? 87% acknowledged ties. Half the people wouldn't answer the survey. I bet that's because they didn't have any ties. Individual authors had ties on average of more than 10 companies. How do you get to be on a guideline panel? This doesn't ask the more important question, what about the conflict of interest of the sponsoring agency? The American Heart Association, I was on their guideline panel for TPA. I was the one vote that voted against it. Afterwards, there was this big thing about, Jeannie Lenzer did this expose about everybody else besides me and one other person possibly had ties to the maker of TPA. She published this in the Lancet, or BMJ, and the Heart Association was outraged, and they said, we have an explicit policy about conflict of interest. Everyone must disclose their conflict of interest. So there were two things that were interesting about that, or three things that are interesting about it. First is, there's pretty good evidence that disclosure is useless. When you say you have a conflict of interest, well, it's like the TV ads for drugs where they say, ask your doctor about, and they list 700 million side effects, including death and paralysis. You don't pay attention. You're sort of overwhelmed by it. Everybody says, oh, I have, the New England Journal frequently now has for its major articles, they don't list the conflict of interest because they can't fit it in the paper. They say you have to go to the appendix to see, because it takes 3 pages to write all the conflict of interest that the authors have. We ignore them. And there's good research, psychological research data, that disclosure has no effect on anything good. So one problem is disclose. The other thing that was interesting was, so the Heart Association said, we disclose conflict of interest. So she asked them, what are the conflict of interest? How come nobody knows about them? And they said, oh, it's private information. It's non-disclosed disclosure. But the other point I wanted to make was, one thing that nobody ever talked about at the time until she wrote this up was, what about the Heart Association itself? Well, Genentech had just built them their new $11 million building. So how did the panel get picked, do you think? ACEP has recently changed their policy about TPA, and I'm not going to tell you the whole story. You know that there's lots and lots of countries. How much money does ACEP get from industry? So, there's all this stuff, many articles in here about conflict of interest, that they are the large majority of panelists and even a larger majority of panel chairmen. And of course, the sponsoring agencies often have their own stuff. There's many articles on why they distort things. There's also articles, by the way, I listed here. I don't think I put it as a separate abstract, but there's one that I don't want to skip over, which says, in primary care, you think we have it bad. In primary care, somebody went through the guidelines of the 10 most common things that essentially all elderly primary care patients have. And they said, in order to actually address each of the issues that are mandated in these 10 major guidelines, you would have to spend 125% of your entire clinical hours for any primary care physician to do that, just to address the questions that you're supposed to address in the guideline. Oh, and by the way, they frequently disagreed with each other. And of course, every elderly person has, 12 guidelines that are relevant to them about preventing falls and dementia and bone minerals and a million things, right? So anyway, number 27, I'll suggest as an important one. And again, there are so many of these. These are just for your reference. Number 27 is written by Jeannie Lenzer, which is entitled "Why We Can't Trust Guidelines," and it discusses the recent ACEP guidelines and the recent guidelines, the old guidelines from the American Academy of Neurology about steroids for spinal cord injury. And there's terrible, fascinating stories about both of them that I'm not going to get into, but this is a good read. One of the other things, so what else? There's guidelines about primary care guidelines being bad and about internal medicine guidelines being bad and how guidelines can harm patients. What about malpractice? So 32 and 33 say, we're very worried about them, and they can, of course, be used against you. You didn't follow the guidelines. On the other hand, they point out that they can be used for you. I followed the guidelines that it may offer a safe legal harbor. Unfortunately, every patient's different, right? So when there's a bad outcome, very often it may have to do with an individual patient that had nothing to do with the guideline. And so number 33 makes what I think is a reasonable suggestion. It says guidelines should never be interpreted as the standard of care. They should at best be interpreted as expert testimony. A bunch of experts got together and this is what they said. That's the same as some witness getting up and saying, this is what I think. But there shouldn't be the answer. Now, of course, should has very little relevance to our legal system, right? Because it very often does things that have nothing to do with should. I can't tell you more about that. There have been efforts among physician groups to get codified in regulations and law that if you follow the guideline, you're safe. And I think there are a couple where that's actually passed, but I don't know what it actually, courts can throw that at their discretion. The court does whatever it wants. The judge can do whatever they want, essentially. So this is a pretty bad picture, right? So how can we do better? I'm going to stop by just mentioning number 38, and then throw it open to you if you'd like. 38 is a paper that I wrote with Jeannie Lenzer and with Kurt Furberg and John Ioannidis. Kurt Furberg was the guy who wrote the All-Hat study, the biggest study about hypertensive drugs, and John Ioannidis is the current flavor of the decade as intellectual in medicine. He's written all sorts of great papers about what's wrong with the literature and why we should be skeptical, etc. He's a very, very smart guy. And for those of you who are interested, there's a wonderful article about him in The Atlantic magazine. Probably 5 years ago, you write me, I'll send you the thing. A really neat discussion of this guy and the concepts that he has been pushing. They're very similar to things you've heard me say many, 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 many times, so I like him. But he's a really smart guy. Anyway, we wrote this paper which said, how can we do better with guidelines? And we actually made a challenge to journals, and this was published in the BMJ, which is different than almost all the other major journals. It has far less ties to industry. It's far less dependent for its dollars on industry, and it has recently been on this sort of crusade about ethics and et cetera. So we wrote this, and we actually challenged all journals to agree to this, and they didn't. Nobody else has agreed. But what we said was, we think there should be rules for guidelines, and they should include some of the following things. One is, they shouldn't be made up of people, there should be no conflict of interest. The people who are on the panel shouldn't be conflicted. There's no reason for that. The claim that you can't get experts who aren't conflicted is crazy. There's lots of evidence of that. There's plenty of people who are not conflicted. We also said that conflict, there are many types of conflict of interest, but financial conflict of interest is special. It's important. A famous quote from Upton Sinclair, which says, very hard to convince a man of something when his income depends upon not believing it. So financial conflict of interest is different. And you shouldn't have financial conflict of interest in guidelines. You also shouldn't be allowed to stack panels with people who everybody knows what they agree. When I agreed to go on the Heart Association panel, the first question I asked them was, who else is on the panel? And they told me, and I said, I'm not going to be on it. The vote's going to be 13-1. I only was convinced to go on it because they lied to me about what was going to happen to the vote. They said, we know it'll be 13-1, but we still need you for X, Y, Z reason, which turned out not to be true. But you know, I was concerned. They just want me so they can say, we gave you your chance. I knew what the vote was going to be. Everybody knew what the vote was going to be. So anyway, panel stacking is a big problem. We said it can't be stacked in one direction, et cetera. We also said it shouldn't be based on content experts. If the whole notion of this is we're going to look in the literature and see if there is evidence, and the evidence tells us that A is the best way we should go in this particular condition, the people who should decide that are methodology experts. People who know how to read literature. So current guidelines are almost always a bunch of cardiologists who do stenting, write a guideline about stenting, and maybe they pay lip service that they have access to a methods expert to help them with the literature. It should be just the opposite way around. It should be people who are experts at reading the literature, and they should have access to content experts if they have questions. In this case, is there a special reason why, blah, blah, blah. We also said that guidelines should be honest, and they should say when there isn't good evidence, or when the evidence is mixed, so that there may be a few cases where they say this is clearly best. But in most cases they should say, at best, the evidence suggests A, but there are people who believe B, and we're going to tell you why we think A, we recommend A, but we're going to leave room for somebody to write a minority report. Here's why some people think B. It's not proven. This is not proven. We can't give you decimal points why this is better. It's not, we don't know. We think A. The best evidence suggests A. Always in leaving room for, and then there should be a big part which says we don't know the answer, and if it's an important question, we'll leave room for two different people to argue the different sides. We know it's not evidence-based, but I think X, no, I think Y. So we made all those suggestions. We said journals should refuse to print guidelines that don't follow those. No journal has taken us up on our offer so far. Surprisingly, amazingly. Anyway, so I personally don't intend this as a guidelines are bad. We need guidelines for some things. And we certainly need to try to identify crazy variability where it's inappropriate and do better. But we also should be humble about what we know. So much in medicine we don't know. When we test all the things that we already believe, there's evidence that more than half the time, all the practices that are established, when you actually go and test them, are wrong. So we can do a lot better. And I think if we want to do this seriously, we have to get money out of the guideline business. But this is going to involve turning an ocean liner around, and there's a lot of incentive to keep it the way it is. So, can we as individuals do anything about it? I don't know. Can we make ACEP do better? There was a lot of outrage at the ACEP TPA guideline. It got them to reopen the process. I don't know what's going to happen. I would be surprised if anything changes, because there is a lot of money involved. But we do have power if we take it in our own, if we insist. So I don't think we should ever act hopeless.